Kia ora. My name is Dr. Cherye Roche. I am the Gait Doctor. I am a doctor of chiropractic and a biomechanist with a special interest in the management of overuse syndromes in the weight-bearing joints and muscles of the body. In my 25 years of practice, I've developed a series of protocols and procedures to help patients to resolve the problems in their joints and muscles. For more information on me and how I go about helping my patients, you can go to www.gaitdoctor.co.nz, and you can look up my background on LinkedIn by going to my LinkedIn page. So sit back and relax and have a listen while I explain how shin splints come about and how best to manage them so that we can resolve them for good. Now, to begin with, I'm not going to be reading these slides to you. You can pause the audio portion of this presentation and read the slides if you'd like. The slides are simply a prompt for me for what to speak to. So with regard to shin splints, in terms of what they are, the shin splints are an irritation of the tendons on the front or the back of the shin bone or the tibia. And so in the front, they're called anterior tibial tendonitis, and on the back, it's called posterior tibial tendonitis or posterior or anterior tibial tendon disorder. That's simply the long Latin word for shin splints. It's a fairly generic term, shin splints, and it can come from a variety of different causes. But essentially, the treatment from the textbook is rest and ice and massage and compressive taping and elastic wraps and that sort of thing. However, those treatments are for the outcome of the underlying problem. So this presentation is addressing how to attend to the underlying problem so that the treatments work. Because many people who've had shin splints have had the experience where as long as they rest and get lots of treatment, the symptoms go away. As soon as they go back to their regular activity, all the symptoms come back. We're going to talk about how to get that to stop happening and to resolve your shin splints going forward. The main reason that shin splints become recurring or chronic is that the foot is collapsing in the arch too fast and too far. And in doing so, it's pulling on and stressing the anterior tibial tendon and the posterior tibial tendon. Therefore, the way to manage that irritation and take the factor out of the equation that's causing the damage is to control the movement of the foot, particularly in the arch and the forefoot, to treat the underlying cause of the shin splints. So we are going to go through this series of questions, and I want you to ask yourself, if you've got shin splints or you've got shin splints in one leg particularly and not the other one so much, why you and not someone else like you? So if you're having shin splints and you're saying that it's because of your running or because you work on your feet all day, well, why you and why not somebody else who's running the same distance as you are? Why you and not somebody else who's working in the same environment you are? The next question is why one side and not the other? Both your legs are going the same distance for the same amount of time on the same surface in the same footwear. So why one and not the other? The next question is why now rather than a year ago or 5 years ago or 10 years ago? Why now instead of when you were younger? Is it age? Well, again, if it was age, then everyone your age that has had a similar level of activity in their life would be getting shin splints at this point in their life. So did this problem come about because of your job or your sport or an old car accident or an old horse accident or fill in the blank? You think it's your job, then everybody who just does your job who's about your age should have shin splints. That's not true. It's not because you played netball as a kid or because you currently play soccer, because that would be that anybody who played netball as a kid or plays soccer now would have shin splints, and that's not true of everyone. Now, you may have had an accident, a car accident, a horse accident, a bike accident, something like that, and that's unlikely to be causing shin splints. It can cause other things, and it may be a factor, but when you have those accidents, within about 6 or 8 weeks, your body should heal from that. And that's unlikely to be the cause of your underlying shin splints. So whatever it is that you think is causing this is probably not the case. So the answer to these questions is almost always no. It's not one of these things. So the question is, let's ask a better question. Again, putting a bit of a finer point on this, if both feet have gone the same distance and done the same work, why is one weaker or more painful than the other? So oftentimes shin splints gets blamed on weak muscles. And a very well-meaning physiotherapist says we need to strengthen your calf muscle so that this doesn't happen. Well, first of all, if it's weakness in the calf muscles, they should both be weak. If they're not, you have to ask the question, why is one weaker than the other? But the other thing that's true is it's almost never weakness. And oftentimes you can do toe raises and all kinds of things that are not painful in the moment. It's only when you get out and go for a long walk or go for a long run that the shin pain starts to come back. So there's something about the mechanics of your foot. So what would cause weak foot muscles and why would there be asymmetry in those? We're going to talk about that. If it's sport or occupation that you're blaming for the injury or the muscle imbalance, then again, why not everybody else? And the other thing is that oftentimes these things get treated with ibuprofen or steroids or some sort of injection. So you have to ask yourself, do you have pain in your feet or shins because you have a deficiency of ibuprofen or steroids in your blood or your body? No, of course not. So when you have those symptoms, you have a biomechanical problem that's now being treated with a chemical solution. And so that's just treating your symptom and not the underlying cause. So you may well have a decrease in your symptoms from the use of ibuprofen or steroids or other sorts of medical treatments, but that's not going to resolve the problem going forward. It's simply going to give you short term relief. So, what's the most common reason for having foot and or shin pain? The answer, asymmetrical biomechanics, a faulty set of mechanics that's happening in your foot that's impacting into your shins. And what I know for sure is that a body in balance will heal itself. So if we can bring balance to the function of your feet and your shins and your legs, the tendons will no longer be irritated and you will no longer have shin splints. So let's look at a couple of the things that you can look for as clues to whether or not you're a candidate for this underlying biomechanical problem that can be fixed usually by just balancing the feet with orthotics, quite frankly. So here's an example of some, these are extreme examples of people who have asymmetrical foot function. So if you look at the upper left and you look at the wear pattern in the top cover, now these are just the insoles of a pair of shoes that's been pulled out and we're looking at it. Look at the difference in the shape of the holes. Look at the difference in the arches. The one on the right has really pulled the material back, the left not so much. However, on the right, the big toe has really put, and the ball of the foot have really put big marks in there. And the heels are different. If you look in the upper right, this one's a little more subtle, but you can see in that area inside the square that on the shoe on your reading right, on the right side, all the little triangles are there. Whereas on the other shoe, they're gone, which means that this person has worn them off by how they're landing on their foot. And then the bottom one with the jandals, those are actually reversed. The right is on the left and the left is on the right. But look at the heels. So the one side, the hole is right in the center. On the other side, the hole is way over to the middle, which means that in that foot, the heel was way rolling over onto the inside, whereas on the other side, the heel was sitting right in the middle. So if you look at the bottoms of your shoes, or you take out the insole out of your shoes and you look at the top of the top cover on the insole of your shoe, you'll see that there is a different wear pattern in how your feet are putting friction and pressure through the insoles of your shoes. That's an indicator that your feet are out of balance. Okay, now let's look at your actual feet. Now, ideally, what you do is you get your phone out and you turn on the camera and you get someone else to take these views of your feet right from the floor, looking right at your feet from the front and from the back. And if you draw a little line up the middle of your heel so that it's going straight up and down with your heel and it's perpendicular to the bottom of your foot, you'll find that when you stand up, that if your heel is collapsing, you'll see this angle like you do on the bottom. And then look at the front of your feet from the front. Do you have more of a bunion on one side than the other? Do you have more callousing on one side than the other? Are your toenails rolling in? So in that upper picture, Not only does she have a bunion, but notice that the toenail bed on her right foot is pretty much parallel to the ground, whereas on her left foot, it's rolling way in. So as that whole row of bones there in her foot is rolling in because her arch is collapsing, the great toe is rolling in, and you can see that in that toenail bed. You look for these asymmetries in your feet, and if you have these kind of asymmetries, one foot to the other, that's an indicator that you've got an imbalance in your feet, and we need to have a look at how we can bring more balance to your feet to take the stress out of your tendons. So in my clinic, I conduct a clinical exam and I look at your feet and I look at your footwear and we look at your posture and we look at the callousing on your feet and do your arches collapse? And there's a series of functional tests that we do. And after all of that clinical observation, then we do this other very dynamic test for looking at how your feet are moving. So it's one thing to look at your feet when they're standing still or when you're laying on a treatment table and looking at how your feet look. But when we see how your feet are actually functioning when you're standing and walking, we get a great deal more information. This is an example of that. So I use what's called the gait scan, which is a pressure plate on which you can either stand or walk, and there are 4,096 pressure sensors that scan at 1600 hertz. And so it's like little strobe lights going on underneath that map. And that then records the amount of pressure that's there. And when you're walking, it measures the rate at which your foot is moving. So when your feet are moving too far and too fast, that's what creates stress in the tendons in your feet and your legs. So this measures that. Now, this first slide is an indicator of looking at static standing posture. So in this case, we can see that this person, when they're standing relaxed, as if they're balanced, they think they're standing in a balanced way. This person actually has 62% of her body weight on her left foot and 38% on her right foot, if you round the numbers. Now, that's an indicator probably that she has a long left leg. Generally, the long side is the side that has the more pressure, or that she has some sort of pain or dysfunction in her right foot that's severe enough that she is unconsciously shifting onto her left foot. The next part of the assessment using the gait scan system is to do the dynamic assessment, whereby you walk across the plate. That in turn gives us information again about the rate and magnitude. How far and how much is your foot moving? How fast is it moving? So it captures a picture, and 1,000 pictures and millions of pictures is what we get is worth 1,000 words. It gives us a tremendous amount of information. This is an example of the type of information that we get. The red areas indicate where there's too much pressure, and the red dotted line indicates where the center of pressure is. So as your foot goes from heel to toe, the foot is also rolling inward and outward through that process. And the center of pressure shifts from the outside to the inside, back to the outside, back to the inside. So these images give us an indicator of how the foot is moving. And we actually see these images as moving images as well. So in this slide, we can see in the center image a comparison of an abnormal and a normal. So this is a summary of the dynamic moving data. And you can see that the person on the left, the 2 feet on the left, there's a lot of pressure underneath the first and second toe on the ball of the foot and a lot of extra pressure in the heel. You can also see that the dots are further apart, meaning the foot is moving too fast. Whereas on the right side, the dots have a nice little swooping curve. They're about the same distance apart, and the pressures are distributed over the foot more evenly. So the left foot has overpronation in both the rear foot and the forefoot, in the heel and the front of the foot, and the right foot is more normal. Now, based on the data that comes from these images, we then use custom orthotics, functional orthotics, to put under the foot to control the motion. So without the orthotic, you can see on the left there that this person ends up with knocked knees, with arches that collapse, and with bunions. And her right bunion is worse than her left bunion. And so this person has all kinds of pain, including shin splints. When we start talking about orthotics, it's important to appreciate that there are a couple of different factors that go into creating a really highly functional, high-end, high-quality orthotic. The two things that go into that are one, the materials that are used, and number two, the specificity with which they're prescribed. So if a practitioner is simply observing someone walking, it's very difficult for them to get a really good sense of what the foot is doing in motion. Whereas when you use the gait scan, you get much more detailed information. And when that detailed information comes back as data, the data that can then be used to make the orthotics. Historically, there have been various types of orthotics. So in the old days, 20, 30 years ago, orthotics were made of rigid, hard plastic. And although that was helpful for some people, it was bothersome for lots of people because the foot is supposed to move. There are 26 bones in the foot, and it's supposed to move and be dynamic. If you put a rigid piece of hard plastic underneath the foot, you rob the foot of some of its motion, and sometimes you create more problems than you solve. At the other end of the spectrum are the orthotics that are made of cork and leather and foam. And those orthotics, although they look like they've got a nice sort of contour to the foot, they're so flexible and so soft that by the time you put your body weight through them, they really do completely collapse. And oftentimes you'll find, and here's the kicker, when you get orthotics over the counter or you get them from a shop somewhere, um, even oftentimes when they're quote unquote custom made because some sort of process has been gone through, when you actually get the orthotics, they're exactly and precisely the same right to left. All you have to do is look at your orthotics and then look at your feet. Are my feet the same right to left? Probably not. Are my orthotics the same right to left? Often they are, and they shouldn't be. The orthotics need to be matching your feet uniquely right to left and uniquely for you. Now, the materials, instead of using hard plastic or foam or cork, nowadays there are polymers of plastics, which means a mix of different plastics. And those plastics are sensitive to heat. When the heat is high enough, they can mold the plastics to what needs to be done. And then various bits and bobs can be added to the orthotics to control the motion of the foot. So various types of orthotics are made for various environments, and we're going to talk about that next. So there's an orthotic for every purpose under heaven, and I'm not going to go into great detail at this point, but you can see from this, if we kind of go from the top left and go around clockwise, we can make an orthotic, which is like the cushion flex, and the cushion flex is for your nan. It's for someone who's got lots of arthritis in their joints and we don't really want to move their foot around, but we just put a lot of cushion underneath them. A superflex is a generic sort of street orthotic for the average shoe that you wear to work. Then there's the sport orthotics and then a specialist fashion flex orthotic. So the fashion flex is for the very, very dressy shoes, mostly for women. A sport flex is a generic sport orthotic that can be used in soccer or a 2-hour walk on the beach or on the footy pitch. Whereas a run flex is used primarily for running in a straight line. So the design of the orthotic is a little bit different if you're going to be running in a straight line consistently versus stopping and starting and moving back and forth. Also, if you're on the golf course, you're going to have some special needs for being on the golf course. There's a specific orthotic called the Eagle Flex for on the golf course. And then because these orthotics are made in Canada and there's a lot of snow in Canada, there is a skate flex and a ski flex, and those are made more rigid and they're made with materials that can withstand the cold and the wet. All of these orthotics are very high quality. They're made from this polymer of plastics that has memory. So when they flex, they bounce right back immediately to where they came from. So when they're designed to meet the needs of your foot, as the weight of your body deforms the orthotic, it has memory to come back to where it needs to be. Furthermore, because we have things like the fashion flex and the cushion flex and the run flex, we can fit orthotics to meet the needs of your specific footwear. Now, that does not mean that you have to have orthotics for every single pair of shoes that you have. It normally means that you need a pair for sports shoes and a pair for dress shoes or work shoes. Once you get those two, then you can move them from shoe to shoe. Okay, ladies, I can hear you now. Yeah, right. I've had orthotics before. There's no way they fit in my dress shoes. So these are photographs taken at Mi Piace Footwear Shop. The orthotic that you see inside those shoes belongs to the manager of the shop, and these are shoes that she's putting her foot in with her orthotic. So yes, we can make orthotics to fit virtually any foot shoe as long as it has what's called a heel counter, a back to it, so the orthotic doesn't come slipping out. Now, ideally, we don't want you in high heel shoes more than a few hours, a day or two a week. So if you're in high heels all day, every day because of the nature of your work, it's a little more difficult to help you out with your shin splints. But we can put you in orthotics in your dress or your shoes for when you do need them. Okay, so that was a lot of information, and you're probably left with more questions than answers. However, let's ask this final question. So, are you a candidate for gait scan and custom orthotics from the orthotic group, TOG? Ask yourself, do your feet look like the feet in this picture when you walk or run? Now, the only way you're going to know that is if you photograph or videotape your feet. You can get that done at some of the shoe shops. But if your shoes also wear out differently right to left, you need to see me about orthotics. Do you get better when you have rest and treatment only to have the shin splints come back after you return to activity? If yes, then we need to talk. So again, you can find out more about this and about the gait scan and about orthotics at www.gaitdoctor.co.nz. And you can find out more about me and my history and my education and my training at my LinkedIn page. So I look forward to seeing you at the clinic. You are welcome to call 09414-2225 and schedule a discovery session over the phone. So I do a 15-minute telephone consultation just to answer a few of your initial questions. And if it sounds like you're a candidate, then we can schedule a visit for you to come and see me in the clinic. So I look forward to seeing you in the clinic to do a gait scan and do a biomechanical assessment and see if we can't solve your shin splint problem and get you back to activity pain free.